Don't wait. ICU Empiric Therapy Essentials. 1. Suspected sepsis. Confirmed signs: fever or hypothermia, tachycardia, hypotension, altered mental status, suspicion of infection, elevated respiratory rate, evidence of organ dysfunction, e.g., low urine output. Start broad-spectrum antibiotics, e.g., piperacillin, tazobactam, vancomycin. IV fluid resuscitation, 30 milliliters kilograms if hypotensive or lactate TOI-4. Oxygen therapy, vasopressors if MAPOPAT 65 mm guide, e.g., norepinephrine. Monitor urine output and lactate. Start sepsis protocol, early goal-directed therapy. Don't wait for blood culture results, CRP procalcitonin, imaging or infection source confirmation, ICU transfer. Why? Mortality increases by 7 to 10% each hour of delay in antibiotics. Time-sensitive organ damage, kidney, liver, CNS. Early fluid resuscitation reverses shock faster. Confirmatory tests: blood cultures X2, CBC, CRP, procalcitonin, serum lactate, renal liver function tests, chest X-ray, USG abdomen, source-specific imaging. 2. Suspected meningitis encephalitis. Confirmed signs: fever, headache, neck stiffness or photophobia, altered mental status, seizures. Focal neurological signs: positive Kernig's or Brudzinski's sign in adults, bulging fontanelle, high-pitched cry in infants. Start empirical IV antibiotics, e.g., ceftriaxone, vancomycin, ampicillin, if age 50 or immunocompromised. IV dexamethasone before or with first antibiotic dose for bacterial meningitis, airway and seizure management if needed. Antiviral, e.g., IV acyclovir, if viral encephalitis suspected. Elevate head end, avoid hypotension. Don't wait for CT, MRI brain unless signs of raised ICP, lumbar results, ICU bed confirmation. Why? Delay in antibiotics increases mortality and risk of neurological sequelae. Early steroids reduce neurological damage in bacterial meningitis. HSV encephalitis is fatal without early acyclovir. Confirmatory tests: CBC, CRP procalcitonin, lumbar puncture, CSF analysis, gram stain culture, PCR. Neuroimaging, CT MRI, if signs of raised ICP or focal deficits. Blood cultures X2, serum electrolytes, renal liver function. 3. Acute myocardial infarction, STEMI. Confirmed signs: chest pain, pressure, radiating to arm, jaw, diaphoresis, nausea, ECG, ST elevation in 2 contiguous leads or new LBBB, hypotension or bradycardia in inferior MI. Start aspirin 325 mg chewable plus clopidogrel 300-600 mg loading, sublingual nitroglycerin, if not hypotensive. Oxygen if SpO2 90%, IV morphine for pain, anticoagulation, enoxaparin or unfractionated heparin. Initiate plan for PCI or thrombolysis. Don't wait for troponin results, cardiology consult or echo, chest X-ray. Why? Reperfusion within 90 minutes, PCI, or 30 minutes, lysis, is critical. Delay increases infarct size and mortality. Confirmatory tests: troponin IT, serial ECGs, 2D echo, cardiac enzymes, coronary angiography. 4. Suspected pulmonary embolism. Confirmed signs: sudden dyspnea, pleuritic chest pain, tachycardia, hypoxia, hemoptysis occasionally. Signs of DVT, unilateral leg swelling pain. ECG, S1Q3T3 pattern or sinus tachycardia. ABG, hypoxia with low PaCO2. Start oxygen therapy, IV fluids if hypotensive, empirical anticoagulation, e.g., enoxaparin or UFH bolus plus infusion. Consider thrombolysis if massive PE with shock. Elevate legs and initiate DVT prophylaxis for others. Don't wait for CT pulmonary angiography, D-dimer, if high suspicion, Doppler of lower limbs. Why? Massive PE can lead to sudden death. Early anticoagulation reduces clot propagation and mortality. Confirmatory tests: CT pulmonary angiography, D-dimer, lower limb Doppler, 2D echo, RA-RV dilatation, McConnell's sign, ABG, ECG, CXR, anaphylaxis. Confirmed signs: sudden onset breathing difficulty, wheeze or stridor. Hypotension, tachycardia, urticaria, angioedema, flushing, GI symptoms, vomiting, cramps, diarrhea. Recent exposure to allergen, food, insect bite, drug. Start IM adrenaline 0.5 milligrams 1/1000 into mid-thigh. Repeat every 5 to 15 min if needed. High-flow oxygen. IV fluids, crystalloid bolus. IV antihistamines, e.g. chlorpheniramine. IV corticosteroids, e.g. hydrocortisone or methylprednisolone. Prepare for intubation if airway is threatened. Don't wait for serum tryptase, allergy testing, or skin prick test. Confirmatory labs. Why adrenaline is life-saving. Delays increase risk of airway compromise and cardiac arrest. Anaphylaxis is a clinical diagnosis. Treatment is urgent. Confirmatory tests: serum tryptase, if available within 1 to 2 hours, ECG, ABG, CXR, post-stabilization, allergy panel later for long-term planning. 6. Status epilepticus. Confirmed signs: continuous seizure 5 min or recurrent seizures without recovery in between, unconscious or unresponsive patient, tonic-clonic movements or subtle twitching, postictal confusion or neurologic deficit. Start IV lorazepam 4 milligrams, repeat after 5 to 10 min if needed. IV levetiracetam or phenytoin as second line. Oxygen, suction, and airway positioning. IV fluids if hypotensive. Prepare for intubation if ongoing seizures or GCS-8. Don't wait for neuroimaging, CT MRI, EEG, serum electrolytes, neurology consult. Why? Seizures 30 min can cause irreversible brain injury. Early benzodiazepine use stops seizures more effectively. Delayed second-line drugs increase risk of refractory status. Confirmatory tests: electrolytes, calcium, glucose, ABG, neuroimaging, CT brain urgent, EEG if ongoing or non-convulsive status suspected. Toxin screen. 7. Acute asthma exacerbation, status asthmaticus. Confirmed signs: expiratory wheeze, use of accessory muscles, tachypnea, tachycardia, low SpO2, inability to complete sentences, pulsus paradoxus, silent chest, ominous. History of asthma, missed medications, allergen exposure. Start nebulized salbutamol plus ipratropium bromide Q20 mins. Systemic corticosteroids, IV methylprednisolone or oral prednisolone, oxygen to maintain SpO2 92%, magnesium sulfate IV if severe. Prepare for intubation in near-fatal asthma, exhaustion, rising CO2. Don't wait for chest X-ray, ABG, serum electrolytes, spirometry, contraindicated in acute setting. Why? Asthma deaths are preventable. Early bronchodilators and steroids reduce airway inflammation. ABG may be falsely reassuring early. Normal CO2 is bad sign, impending failure. Confirmatory tests: ABG shows hypoxia, CO2 retention in late phase. Chest X-ray, rule out pneumothorax infection. CBC, electrolytes, especially K and Mg quercepi, peak flow when patient stable. 8. Diabetic ketoacidosis, DKA. Confirmed signs: polyuria, polydipsia, dehydration, altered sensorium, small breathing, deep, rapid respiration, fruity odor from breath, history of type 1 or insulin-dependent diabetes. Start IV fluids, normal saline bolus, IV insulin infusion, 0.1 u/kg/r after checking K-key, potassium replacement if KT 5.3 milliliters, frequent glucose and electrolyte monitoring, oxygen if hypoxic. Don't wait for blood gas, serum ketones, complete lab workup, endocrinology referral. Why delays in insulin and fluids worsen acidosis, dehydration, and shock. Potassium monitoring is critical as insulin shifts K intracellularly. Confirmatory tests: ABG shows metabolic acidosis with high anion gap, serum urine ketones, blood glucose, electrolytes, creatinine osmolality, ECG for KT's abnormalities. 9. Hyperosmolar hyperglycemic state, HHS. Confirmed signs: elderly patient with history of type 2 DM, extremely high blood glucose, 600 milligrams per deciliter, severe dehydration, dry mucosa, hypotension, altered mentation, drowsiness, possible seizures. No significant acidosis or small breathing, unlike DKA. Start IV fluids, normal saline bolus, 1 to 2 ounces in first hour, IV insulin infusion, lower dose than DKA, e.g. 0.05 grams per hour. Potassium correction, once urine output is adequate. Monitor blood glucose and serum sodium hourly. Prevent thromboembolism, LMWH prophylaxis. Don't wait for serum osmolality, full lab panel, arterial blood gas, endocrine consult. Why? High mortality rate, 15% due to severe dehydration and electrolyte shifts. Rapid correction of glucose and fluid deficit improves outcomes. Confirmatory tests: blood glucose, serum osmolality, 320 mg/kg, electrolytes, urea, creatinine, ABG, usually near normal pH, serum ketones, absent or mild. 10. Tension pneumothorax. Confirmed signs: sudden onset dyspnea, pleuritic chest pain, absent breath sounds on one side, hyperresonant percussion, hypotension, distended neck veins, tracheal deviation, late, often in trauma or ventilated patients. Start immediate needle decompression, large bore cannula 4 to 16 G in second intercostal space, midclavicular line, followed by chest tube insertion, intercostal drainage in fifth intercostal space, mid-axillary line. High flow oxygen, monitor vitals continuously. Don't wait for chest X-ray or ultrasound, ABG, surgical ICU shift. Why? A true emergency. Tension pneumothorax leads to obstructive shock and cardiac arrest. Clinical diagnosis: imaging can delay life-saving decompression. Confirmatory tests: X-ray, post-decompression to confirm lung re-expansion. Bedside ultrasound, if diagnosis uncertain and patient stable. ABG, hypoxia, CO2 retention. 11. Massive hemoptysis. Confirmed signs: coughing up 300 milliliters of blood in 24 hours or 100 milliliters at once, respiratory distress, hypoxia, gurgling sounds, blood in airway, history of TB, bronchiectasis, lung cancer, or coagulopathy. Start position. Place patient in lateral decubitus with bleeding lung down. Airway secure with large bore ET tube or consider double lumen if available. Oxygens, IV access fluids. Tranexamic acid IV. Reverse coagulopathy if present. FFP, vitamin K, platelets. Call for urgent bronchoscopy or IR embolization. Don't wait for chest X-ray or CT. Source localization. Coagulation profile results. Why? High risk of asphyxiation from blood rather than exsanguination. Prompt airway protection and stabilization. Save lives. Confirmatory tests. Chest CT angiography to localize source. Bronchoscopy. Coagulation panel. CBC, blood type and crossmatch. 12. Acute variceal bleed. Confirmed signs. Hematemesis, vomiting blood, or melena. Hypotension, tachycardia, known cirrhosis or chronic liver disease. Ascites, jaundice, splenomegaly. Start. IV access X2 large bore plus fluid resuscitation. IV octreotide, 50 milligrams bolus, then 50 milligram RR infusion. IV antibiotics, e.g. ceftriaxone 1 gram IV. Proton pump inhibitors, pantoprazole infusion. Urgent GI consult for endoscopy. Prepare for possible blood transfusion. Target HB 7 gram virus. Don't wait for endoscopy, LFT reports or viral markers, ultrasound or CT scan. Why? High mortality risk from rebleeding and infections. Early vasoactive drugs plus antibiotics reduce complications. Confirmatory tests, endoscopy, definitive for varices. LFTs, PT-INR, platelet count. Abdominal ultrasound with portal flow, CBC, crossmatch blood. 13. Suspected aortic dissection. Confirm signs, sudden severe tearing chest back pain, pulse deficit or BP difference between arms, new diastolic murmur, aortic regurgitation. Neurological symptoms if branch vessel involved, history of hypertension, Marfan's, or bicuspid aortic valve. Start tight BP control, IV beta blocker, e.g. esmolol or labetalol to keep SBP 120 mm Drang and HR 60. Add IV nitroprusside if SBP still high after HR control. Analgesia, IV opioids, immediate vascular surgery cardiothoracic consult. Prepare for CT aortogram or TEE. Don't wait for CT aortogram or D-dimer, echo or ECG findings, cardiac enzymes. Why? Uncontrolled BP increases propagation risk and mortality. Every hour delay increases death risk by 1%. Confirmatory tests. CT aortogram, gold standard, transesophageal echo. Chest X-ray may show widened mediastinum. ECG to rule out MI. 14. Acute ischemic stroke within thrombolysis window. Confirmed signs, sudden onset of focal neurological deficit, weakness, speech loss, facial droop. Onset 4.5 hours, GCS 8, airway patent. Rule out hypoglycemia, check RBS. NIHS score to assess severity. Start, secure airway if needed. Check blood sugar, correct hypoglycemia. Keep BP 185-110 mm Hg before thrombolysis. Use labetalol or nicardipine if needed. Immediate non-contrast CT brain. Inform neurologist, stroke team. Prepare for RTPA, alteplase, if within window and no contraindications. Don't wait for MRI brain. Detailed lab reports unless critical. Coagulation, platelets, sugar. Specialist opinion delay. Why? Time is brain. Up to 2 million neurons die every minute. Early thrombolysis greatly improves outcome. Confirmatory tests, non-contrast CT brain, coagulation profile, CBC, RBS, LFT, RFT, ECG, cardiac enzymes to rule out stroke mimics. 15. Acute stroke, hemorrhagic. Confirmed signs, sudden focal neurological deficit with decreased consciousness, severe headache, vomiting, seizures, hypertension at presentation, often seen in patients with history of uncontrolled BP or anticoagulant use. Suspected if no trauma history but signs of raised ICP. Start, secure airway and breathing. Head elevation to 30 degrees NPO, nil per os. Strict BP control 1,4P to 160 millimeter grams using IV labetalol or nicardipine. Mannitol 0.25 to 1 gram Coldra IV bolus for raised ICP if herniation suspected. Stop anticoagulants, antiplatelets if patient is on them. Start neurosurgery, neurology, consult immediately. Monitor GCS, pupils, vitals hourly. Don't wait for coagulation profile or full labs. Surgical opinion, platelet count unless planning surgery. Why? Hematoma expansion occurs in the first 3-6 hours. Early BP and ICP control improves survival and reduces expansion. Confirmatory tests. Urgent NCCT brained, PT-INR, platelet count, CBC, RBS, LFT, RFT, ECG, chest X-ray. 16. Acute heart failure with pulmonary edema. Confirmed signs, sudden breathlessness, orthopnea, pink frothy sputum, bilateral basal crepitations, raised JVP, hypoxia, diaphoresis, cold extremities, tachycardia, hypertension or hypotension. CXR, bat wing pattern, if available early. Start position, sit upright with legs down. Oxygen or NIV, BiPAP if in distress or hypoxic. IV loop diuretic, furosemide 40-80 milligrams. IV vasodilators, nitroglycerin infusion if BP 100 milligrams. Morphine low dose if severe anxiety. Start inotropes, e.g. dobutamine if signs of cardiogenic shock. Monitor ECG, urine output, and ABG don't wait for, echo or BNP. Chest x-ray confirmation, full blood reports. Why? Pulmonary edema rapidly worsens without prompt preload-afterload reduction. Early diuresis and oxygenation prevent intubation and ICU progression. Confirmatory tests: ECG, chest x-ray, echocardiogram, NT-proBNP, troponins, ABG, CBC, LFT, RFT electrolytes. 17. Cardiac tamponade. Confirmed signs: hypotension, muffled heart sounds, distended neck veins, Beck's triad, pulsus paradoxus, 10 mm/gram, drop in SBP during inspiration, tachycardia, dyspnea, narrow pulse pressure, often seen post-MI, malignancy, TB, uremia, or trauma. Echo not immediately available in some settings. Start: high-flow oxygen, urgent pericardiocentesis if trained personnel available. Prepare pericardiocentesis tray bedside, volume expansion with IV fluids to maintain preload. Monitor vitals, ECG, and signs of clinical improvement. Arrange for urgent bedside echo. Don't wait for echo confirmation if clinical signs are clear and patient crashing. Pericardial fluid analysis or full lab panel. Why? Tamponade causes obstructive shock. Delay leads to cardiac arrest. Even temporary pericardial drainage can stabilize patient. Confirmatory tests: echocardiography, gold standard. ECG, low voltage QRS, electrical alternans. Chest x-ray, enlarged cardiac silhouette, CBC, RFT, coagulation profile. 18. Organophosphate poisoning, confirmed signs. History of exposure, farmer, suicidal ingestion, pesticide contact. Sludge symptoms, salivation, lacrimation, urination, diarrhea, GI upset, emesis. Meiosis, bradycardia, bronchorrhea, fasciculations, altered sensorium, seizures, respiratory distress. Start: decontamination, remove clothes, wash skin. Airway protection, oxygen, mechanical ventilation if needed. Atropine 2 to 5 milligrams IV bolus. Repeat every 5 to 10 minutes until secretions dry and heart rate normalizes. Pralidoxime 2 PAM, 1 2-gram IV over 15 to 30 mins. Repeat Q6 to 12H. IV fluids. Monitor vitals and SpO2. ICU transfer immediately. Don't wait for cholinesterase levels, toxicology panel, exact name or dose of pesticide. Why? Delayed atropine can result in fatal respiratory failure. Early intervention dramatically reduces mortality. Confirmatory tests: RBC cholinesterase level, but not urgently required. ABG, ECG, electrolytes, renal liver function, chest x-ray, if respiratory involvement. 19. Carbon monoxide poisoning. Confirmed signs: history of exposure, fire, closed garage, generator fumes, headache, confusion, nausea, vomiting. Cherry red lips, rare, altered mental status, seizures, syncope. Pulse oximeter falsely normal, SpO2 not reliable. Start: 100% oxygen via non-rebreather mask immediately. If unconscious or severely symptomatic, consider intubation plus mechanical ventilation. Cardiac monitoring and ABG. Consider hyperbaric oxygen if available. Severe cases, COHB 25%, pregnancy, loss of consciousness. Don't wait for carboxyhemoglobin level, ABG confirmation, radiology. Why? Carbon monoxide binds hemoglobin 200x more than oxygen, cellular hypoxia. Early oxygen therapy reduces tissue injury and improves survival. Confirmatory tests: carboxyhemoglobin levels via co-oximetry, ABG with lactate, ECG, cardiac enzymes, CT brain if seizures or altered sensorium. 20. Suspected air embolism. Confirmed signs: sudden hypotension, dyspnea, altered mental status during or after central line insertion, hemodialysis, neurosurgery, or laparoscopic procedure. Mill-wheel murmur, churning sound over precordium. Cardiovascular collapse, stroke-like symptoms. Start: immediately place patient in left lateral decubitus plus Trendelenburg position, high flow 100% oxygen. If central line in place, aspirate air via catheter. Start IV fluids to maintain circulation. Prepare for hyperbaric oxygen therapy if severe. Don't wait for CT chest, echocardiography, confirmation of air on imaging. Why? Air embolism rapidly obstructs pulmonary circulation, sudden cardiovascular collapse. Postural maneuvers in oxygen can reduce size and movement of embolism. Confirmatory tests: transesophageal echocardiography, chest CT, or Doppler ultrasound in venous air embolism, ABG, ECG. 21. Acute adrenal crisis. Confirmed signs. History of steroid use, adrenal insufficiency, or recent stress, surgery, sepsis. Hypotension refractory to fluids, weakness, abdominal pain, confusion, vomiting. Hyponatremia, hyperkalemia, hypoglycemia. Start. Ava hydrocortisone 100 mg stat, then 50 to 100 mg Q6H. IV fluids, normal saline bolus 1,2 elo. Dextrose 50% if hypoglycemic. Empirical broad-spectrum antibiotics if febrile. Don't wait for cortisol levels, ACTH stimulation test, electrolyte reports. Why? Adrenal crisis is life-threatening and may present as shock. Corticosteroid replacement reverses symptoms rapidly. Confirmatory tests, serum cortisol and ACTH, electrolytes, blood glucose, blood cultures if febrile. 22. Thyroid storm. Confirmed signs, history of untreated, poorly managed hyperthyroidism. Fever, tachycardia, out of proportion to fever, altered mental status, diarrhea, tremor, agitation, heart failure, atrial fibrillation. Start propranolol 60-80 mg PO/Q6H or IV. PTU 600,000 mg loading dose, then 200 to 250 mg Q4H, or methimazole, IV hydrocortisone 100 g Q8H. Iodine, Lugol solution, or sodium iodide I4. 1 hour after antithyroid drug. Cooling, IV fluids, oxygen. Don't wait for T3, T4, or TSH results, confirmation of thyroid function tests. Why? Thyroid storm carries a mortality of up to 30 to 50% without treatment. Early beta blockade, antithyroid drugs, and steroids prevent decompensation. Confirmatory tests, TSH, free T3, free T4, CBC, LFTs, ABG, ECG, chest X-ray. Thyroid antibody panel, if suspected autoimmune. 23. Myxedema. Coma, confirmed signs, elderly patient, history of hypothyroidism or undiagnosed thyroid disease, hypothermia, bradycardia, hypotension, altered sensorium, respiratory depression, hyponatremia, hypoglycemia, macroglossia, dry skin, delayed reflexes. Start. IV levothyroxine, T4, 200-400 mg bolus, then 50 to 100 mg per day. IV hydrocortisone, 100 mg Q8H until adrenal insufficiency ruled out. IV fluids with dextrose if hypoglycemic. Passive rewarming, ventilatory support if needed. Don't wait for TSH or T4 levels, cortisol results, sodium or glucose levels. Why? Mortality 30% if untreated. Delay in thyroid hormone and steroid therapy may be fatal. Confirmatory tests, TSH-free T4, serum cortisol, ABG, sodium glucose, ECG, chest X-ray. 24. Hyperkalemia, confirmed signs, history of CKD, dialysis, ACE inhibitors, potassium-rich diet, muscle weakness, flaccid paralysis, palpitations. ECG, tall peak T waves, wide QRS, sine wave pattern. Start. IV calcium gluconate 10%, 10 milliliters over 10 mins, cardio protection. IV insulin plus dextrose, 10 units regular insulin, 50 milliliter 25% dextrose. Nebulized salbutamol 10 to 20 milligrams. IV furosemide, sodium bicarbonate if acidotic. Dialysis if severe or refractory, don't wait for. Serum potassium confirmation, ABG or renal function tests. Why? Hyperkalemia can cause life-threatening arrhythmias. ECG changes may precede lab confirmation. Confirmatory tests, serum electrolytes, ABG, ECG monitoring, renal function tests, urine potassium if needed. Ready for the next batch. Send anytime. 25. Hypokalemia. Confirmed signs, history of diuretic use, vomiting, diarrhea, insulin therapy, muscle cramps, weakness, ill use, palpitations. ECG, flattened T waves, U waves, ST depression, arrhythmias. Start. IV potassium chloride 10 to 20 mmHg per hour via central line, slow infusion. Oral potassium supplementation if mild and patient is conscious. Monitor ECG continuously. Don't wait for complete electrolyte panel, ABG or magnesium results. Why? Severe hypokalemia can cause fatal arrhythmias. Neuromuscular symptoms may rapidly worsen. Confirmatory tests, serum potassium magnesium ABG to check for alkalosis, EC26, hypoglycemia with altered sensorium. Confirmed signs, diabetic on insulin oral agents, alcohol use, sepsis, confusion, agitation, seizures, coma, random blood sugar 70 milligrams per deciliter. Start IV dextrose 50%, 25 to 50 milliliter stat. If no IV access, 1 milligrams IM glucagon. Maintain with 10% dextrose drip if prolonged risk. Treat underlying cause. Don't wait for lab confirmation of glucose, neurologist review or imaging. Why? Brain relies solely on glucose. Delay can lead to irreversible damage. Prompt correction is often diagnostic and therapeutic. Confirmatory tests, RBS, serum insulin C-peptide if needed, ketones, ECG electrolytes, CT brain if symptoms persist despite correction. 27. Hypocalcemia with tetany, confirmed signs, perioral numbness, tingling, muscle cramps, carpopedal spasm, positive Schwastex and Trousseau's signs, ECG, prolonged QT interval, recent neck surgery, pancreatitis or sepsis. Start IV calcium gluconate 10%, 10 to 20 milliliters diluted in 100 milliliter NS over 10 to 20 minutes. Monitor ECG during infusion. Recheck calcium every 4 to 6 hours. Treat underlying cause, e.g. magnesium correction if low. Don't wait for serum calcium confirmation, PTH, magnesium, phosphate levels. Why severe hypocalcemia can cause life-threatening laryngospasm or arrhythmias. Confirmatory tests, serum total and ionized calcium, magnesium, phosphate, PTH. ECG 28, meningococcal sepsis in pediatrics. Confirmed signs, child with sudden high fever, purpuric rash, hypotension, altered mental status, neck stiffness, photophobia, bulging fontanelle, infants. Signs of shock, cold extremities, capillary refill, 3 secs. Start IV ceftriaxone or cefotaxime if 1 month old. Fluid resuscitation with crystalloids. Vasopressors if hypotensive after fluids. Monitor airway and neurologic status. Consider steroids, dexamethasone if indicated. Don't wait for blood cultures or lumbar puncture, neurologist opinion or CT brain. Why? Meningococcal sepsis is fulminant. Early antibiotics save lives. Delays can lead to DIC, multi-organ failure, death. Confirmatory tests, CBC, CRP, procalcitonin, blood cultures, LP with CSF analysis if safe, CT brain if LP deferred, coagulation profile. 29. Acute epiglottitis, confirmed signs, sudden onset sore throat, high fever, muffled hot potato voice, drooling stridor sitting in tripod position, rapid progression, especially in children. Risk factors, unvaccinated child, diabetes in adults. Start airway protection, prepare for early intubation in OT with ENT anesthetist. IV antibiotics, ceftriaxone or cefotaxime, vancomycin. IV steroids, dexamethasone to reduce airway edema. Oxygen via face mask, avoid distressing the patient. Don't wait for throat examination or swab, may worsen obstruction. Imaging, X-ray lateral neck or CT. Why? Risk of sudden airway obstruction is high and unpredictable. Early airway management can prevent death. Confirmatory tests, blood cultures, lateral neck X-ray, thumb sign if safe. Laryngoscopy under controlled conditions, not in ED. 30. Acute bacterial endocarditis. Confirmed signs, fever plus new murmur or changing murmur, splinter hemorrhages, Osler nodes, Janeway lesions. Positive history, IVDU, prosthetic valve, prior valve disease. May present with embolic phenomena, stroke, renal infarcts. Start empirical IV antibiotics, vancomycin, ceftriaxone, blood cultures X3 from different sites before starting antibiotics if time allows. Monitor for heart failure, arrhythmias, septic emboli. Don't wait for culture reports or echocardiogram before starting antibiotics if unstable. ID consultation if clinical suspicion is high. Why? Delay in therapy increases risk of valve destruction, embolism, and mortality. Early antibiotics reduce complications. Confirmatory tests, blood cultures, transthoracic or transesophageal echocardiogram, inflammatory markers, ESR, CRP. Duke criteria for diagnosis. 31. Severe anemia with hypoxia. Confirmed signs, pallor, tachycardia, hypotension, dyspnea at rest, low SpO2 despite oxygen therapy. Known history of chronic disease, recent bleeding, or hemolysis. HB 5 to 6 Grailon POC test or clinical judgment in emergencies. Start supplemental oxygen, transfusion of packed red blood cells, PRBCs, urgently. Type specific or O negative if cross-match delayed. IV access, cardiac monitoring. Identify source of blood loss or hemolysis concurrently. Don't wait for full CBC or cross-match in hemodynamically unstable patient. Confirmatory hemolysis bleeding source if clear clinical anemia with hypoxia. Why? Hypoxia from low oxygen carrying capacity can cause myocardial or cerebral ischemia. Timely transfusion can prevent multi-organ failure. Confirmatory tests, CBC, reticulocyte count, peripheral smear, Coombs test if hemolysis suspected. Iron studies, LFTs, LDH, and haptoglobin. 32. Acute upper GI bleed. Confirmed signs, hematemesis, melena, hypotension, tachycardia, pallor, low hemoglobin, history of NSAID use, liver disease, varices, PUD, shock or altered sensorium and massive bleed. Start large bore IV access, 2 lines, IV fluids, crystalloids, PRBC transfusion as needed. IV proton pump inhibitor, PPI, e.g. pantoprazole 80 mg bolus plus infusion. IV octreotide if variceal bleeding suspected. NPO, NG tube for decompression if needed. Prepare for urgent endoscopy. Don't wait for endoscopy to start PPI or octreotide. Full lab workup before resuscitation. Why? Delay in hemodynamic stabilization worsens mortality. Early PPI and octreotide reduce rebleed and improve endoscopic visualization. Confirmatory tests, CBC, LFTs, INR, endoscopy, diagnostic therapeutic, cross-match for transfusion, urea often elevated in upper GI bleed. 33. Acute lower GI bleed, confirmed signs, hematochezia, fresh red blood per rectum, sudden onset rectal bleeding with or without pain, hemodynamic instability, tachycardia, hypotension, known history of diverticulosis, IBD malignancy, or anticoagulant use. Start, large bore IV access, oxygen, monitor vitals. IV fluids, NSRL for resuscitation, blood transfusion if HB7 Griemploide or ongoing bleeding. Hold anticoagulants, antiplatelets if safe. Prepare for colonoscopy surgical referral. Don't wait for colonoscopy or CT angiography before stabilizing vitals. Full coagulation profile before holding anticoagulants in critical bleeding. Why? Early resuscitation improves perfusion and outcomes. Bleeding can be brisk and cause rapid deterioration. Confirmatory tests, CBC, PT, INR, LFTs, colonoscopy, CT angiography in active severe bleeding. Stool occult blood, non-urgent cases. 34. Febrile neutropenia, confirmed signs. Temperature, 38.3 degrees C or 38 degrees Celsius for over 1 hour. ANC, absolute neutrophil count, 500 cells millimeter or expected to fall 500. Recent chemotherapy, hematologic malignancy, or immunosuppressive therapy. May have no localizing signs of infection. Start empiric broad-spectrum IV antibiotics immediately, e.g. piperacillin tazobactam or cefepime pasamicicin. Isolate patient to prevent further exposure. IV fluids, oxygen if needed. Monitor vitals and organ function closely. Don't wait for blood culture, urine culture, chest x-ray, or ANC report. Localizing symptoms or signs. Why? Every hour of delay increases mortality. Neutropenic patients deteriorate rapidly without typical inflammatory signs. Confirmatory tests, CBC with differential, ANC count, blood urine cultures, chest x-ray, CRP, procalcitonin, LDH, 35, acute pancreatitis, confirmed signs, sudden onset epigastric pain radiating to the back, nausea, vomiting, history of alcohol use or gallstones, tender epigastrium, guarding, tachycardia, hypotension in severe cases. Start IV fluids, aggressive hydration with Ringer's lactate, NPO, nil per oral, bowel rest. Pain management, IV opioids, oxygen, monitor vitals and urine output, ICU admission if severe. Don't wait for lipase amylase reports, CT scan in first 48 hours unless suspicion of necrosis or other complication. Why? Early hydration within the first 24 hours reduces mortality and prevents complications. Delaying fluids leads to worsening SIRS and organ failure. Confirmatory tests, serum lipase and amylase, abdominal ultrasound to assess for gallstones, CT abdomen after 48 hours or if severe, CRP, CBC, LF-bun, calcium. 36. Suspected necrotizing fasciitis, confirmed signs, rapidly progressive skin infection with severe pain, swelling, erythema, pain out of proportion to exam, skin blistering, crepitus, necrosis, signs of sepsis, hypotension, tachycardia, risk factors, diabetes, trauma, immunosuppression. Start IV broad-spectrum antibiotics, e.g. meropenems, clindamycin, vancomycin. Urgent surgical consult, fasciotomy, debridement, fluids resuscitation, oxygen, hemodynamic monitoring. ICU admission. Don't wait for MRI or surgical biopsy, blood culture or swab culture. Why? Rapid tissue destruction with high mortality. Delay in surgery significantly worsens outcomes. Confirmatory tests, CBC, CRP, lactate, blood cultures, CT MRI if time permits before surgery. Surgical exploration, gold standard. 37. Suspected peritonitis. Confirmed signs, severe abdominal pain with guarding and rigidity, rebound tenderness, absent bowel sounds, fever, tachycardia, cough, hypotension. History of perforated ulcer, recent surgery, ascites, or dialysis. Start IV broad-spectrum antibiotics, e.g. piperacillin tazobactam's metronidazole. IV fluids, electrolyte correction, NPO nasogastric decompression, urgent surgical consult, ICU monitoring if signs of sepsis shock. Don't wait for abdominal X-ray CT, culture results. Why? Delays in antibiotics or surgical intervention increase mortality. Early source control is critical. Confirmatory tests, X-ray abdomen, erect, free air under diaphragm, ultrasound or CT abdomen, CBC, CRP, LFT, renal function tests, diagnostic peritoneal tap if ascites. 38. Acute mesenteric ischemia, confirmed signs, sudden severe abdominal pain out of proportion to physical findings, nausea, vomiting, bloody diarrhea. Risk factors, atrial fibrillation, embolism, atherosclerosis, metabolic acidosis or elevated lactate. Start IV fluids, oxygen, NPO, IV broad-spectrum antibiotics, e.g. ceftriaxone plus metronidazole. urgent surgical consult or vascular intervention, anticoagulation if embolic cause suspected, ICU admission. Don't wait for CT angiography if clinically obvious blood gas results. Why? Irreversible bowel necrosis can occur within hours. Early intervention prevents multi-organ failure. Confirmatory tests, CT angiography, gold standard, serum lactate, ABG, CBC, coagulation profile, ECG, 39, spinal cord compression. Confirmed signs, acute onset back pain, often severe and localized, motor weakness, sensory loss, or numbness below lesion level, urinary retention or incontinence, history of malignancy, tuberculosis, or trauma. Start IV methylprednisolone, e.g. 30 milligrams kilogram bolus, then 5.4 milligram killer infusion for 24 to 48 hours if trauma. Empirical antitubercular therapy, ATT, if TB spine suspected. Urgent MRI spine, neurosurgery or orthospine consult. Strict bed rest, bladder care, DVT prophylaxis. Don't wait for MRI or biopsy in cases with clear signs or history of known malignancy. ESR, CRP, or gene expert. Why delayed decompression, 6 hours, leads to irreversible paralysis. Steroids reduce cord edema and preserve function. Confirmatory tests. MRI spine, gold standard. ESR, CRP, serum calcium. X-ray spine, CBC, LFTs, renal function. 40. Acute limb ischemia. Confirmed signs. The 6 Ps, pain, pallor, pulselessness, paresthesia, paralysis, poikilothermia, sudden onset in a previously normal limb, history of atrial fibrillation, atherosclerosis, or embolic risk. Start IV unfractionated heparin bolus, e.g. 80 U kilogram, followed by infusion 18 U kilograms per hour. Pain control. Urgent vascular surgery consult. ECG to check for AF, NPO and pre-op preparation. Don't wait for. Doppler or CT angiography if clinical signs are overt. Full coagulation panel. Why? Limb salvage depends on early revascularization within 6 hours. Delays lead to irreversible muscle and nerve damage. Confirmatory tests. Doppler ultrasound, first line. CT angiography to plan revascularization. ABG, lactate, CBC, PTINR, APTT. 41. Guillain-Barré syndrome, GBS, with respiratory involvement. Confirmed signs. Symmetrical ascending weakness, absent deep tendon reflexes, difficulty in swallowing, speaking, or breathing, reduced single breath count, NIF 30 cm H2O, or VC 20 milliliters kilokilogram, autonomic instability, e.g. fluctuations in BP or heart rate. Start secure airway if signs of impending respiratory failure. Shift to ICU for monitoring. IVIG 0.4 gram per kilo day, 5 days, or plasmapheresis. DVT prophylaxis, physiotherapy. Don't wait for nerve conduction studies or CSF results. Confirmatory antibody panels. Why? Respiratory failure can develop rapidly and be fatal. Early treatment improves outcomes and reduces ICU stay. Confirmatory tests, nerve conduction velocity, NCV, EMG, CSF, albuminocytologic dissociation, antiganglioside antibodies, e.g. anti-GM1, 42. Pediatric septic shock, confirmed signs, fever or hypothermia, tachycardia, altered mental status, poor perfusion, delayed CRT, modeling, cold extremities. Hypotension is a late sign in children. Oliguria. Start high flow oxygen, rapid fluid boluses, 20 milliliters plasma light, up to 60 milliliters kilograms. Empirical antibiotics within 1 hour, e.g. ceftriaxones, vancomycin. Vasopressors if fluid refractory, e.g. dopamine, epinephrine. Monitor glucose and electrolytes. Shift to PICU. Don't wait for. Blood culture procalcitonin or CRP, lab confirmation of sepsis. Why? Mortality rises with each hour of delay. Children compensate until sudden decompensation. Confirmatory tests, blood cultures, CBC, CRP, procalcitonin, lactate, LFT, RFT, CXOUSG abdomen if focus unclear. 43. Eclampsia. Confirmed signs, pregnant or postpartum woman with generalized tonic-clonic seizures, hypertension, SBP 140, DBP 90, proteinuria, possible headache, visual changes, epigastric pain. Start magnesium sulfate, 4 gram IV loading over 20 mins, then 1 gram hour infusion. Control BP. Labetalol or hydralazine IV. Secure airway and oxygen support. Fetal monitoring if antepartum. Prepare for delivery. Vaginal preferred unless contraindicated. Don't wait for urine protein reports, CT scan unless suspecting intracranial bleed. Why? Seizures can recur and worsen maternal fetal outcome. Delay in MEMG-SOCOR increases mortality and complications. Confirmatory tests, urine dipstick, protein, creatinine ratio, CBC, LFTs, RFTs, fundoscopy, neuroimaging if atypical signs. 44. Postpartum hemorrhage, PPH. Confirmed signs, blood loss 500 milliliters after vaginal delivery or 1,000 milliliters after C-section. Signs of hypovolemia, tachycardia, hypotension, pallor, altered sensorium. Uterus may be boggy, atony, or firm, trauma, retained tissue. Start uterine massage, oxytocin infusion, methylergometrine or carboprost, large bore IVs plus rapid fluid resuscitation, crystalloids plus blood, tranexamic acid 1 g IV within 3 hours. Prepare for surgical intervention if bleeding persists. Monitor vitals, urine output, and coagulation status. Don't wait for exact measurement of blood loss, coagulation panel or cross-match. Start O-negative blood if needed. Why? Leading cause of maternal mortality. Rapid correction can be life-saving and uterine-sparing. Confirmatory tests: CBC, PT, INR, APTT, fibrinogen, USG pelvis if retained tissue suspected, cross-match, ABG lactate. 45. Acute angle closure glaucoma. Confirmed signs: sudden onset, severe eye pain, often unilateral, blurred vision, halos around lights, nausea, vomiting, red eye with mid-dilated fixed pupil, hard, tender eyeball on palpation. Start timolol eye drops, beta blocker. Acetazolamide I4 or PO, 500 mg stat. Mannitol IV 20%, 1 to 2 gram kilogram over 30 to 60 mins if severe. Pilocarpine 2% drops after IOP starts lowering. Urgent ophthalmology referral. Don't wait for formal intraocular pressure IOP measurement. Ophthalmologist to arrive if classic signs present. Why? Delayed treatment can lead to permanent vision loss within hours. Early IOP control improves prognosis dramatically. Confirmatory tests: tonometry, IOP 40 mm/g usually, slit lamp examination, gonioscopy if available. 46. Methanol poisoning. Confirmed signs: history of ingestion of country liquor or industrial alcohol, visual symptoms, blurred vision, photophobia, snowfield vision, GI, nausea, vomiting, abdominal pain, CNS depression, high anion gap metabolic acidosis. Start IV sodium bicarbonate for acidosis, IV ethanol or fomepizole if available to inhibit alcohol dehydrogenase. Folinic acid, leucovorin 1 mg/kg IV every 6 hours. Dialysis if severe acidosis, renal failure, or visual symptoms. Don't wait for methanol levels. Confirmed metabolic acidosis if strong clinical suspicion. Why? Methanol metabolizes into formic acid, causing blindness and death. Antidotes must be given early to prevent toxicity. Confirmatory tests: ABG, metabolic acidosis with high anion gap. Serum methanol level may not be readily available. Osmolar gap, visual evoked potential in some cases. 47. Paracetamol, overdose, confirmed signs. History of ingestion, often 150 mg/kg or 10 grams in adults. Nausea, vomiting, RUQ pain, early. Jaundice, encephalopathy, coagulopathy, late. May be asymptomatic initially. Start N-acetylcysteine, NA-Phe immediately. Don't wait for levels. IV, 150 mg over 1 hour, 50 mg/kg over 4 hours, 100 mg/kg over 16 hours. Activated charcoal if within 1 to 2 hours of ingestion. Don't wait for serum paracetamol levels, signs of liver damage, INR LFT results. Why? Nekis is most effective within 8 hours. Delays increase risk of acute liver failure. Confirmatory tests: serum paracetamol levels at 4 hours post-ingestion. LFTs, INR, AB, blood glucose, creatinine. 48. Suspected brain herniation. Confirmed signs: sudden deterioration in GCS, fixed dilated pupils, Cushing's triad, hypertension, bradycardia, irregular breathing. Posturing: decerebrate, decorticate. CT shows midline shift, compressed ventricles. Start elevated bed to 30 degree. Hypertonic saline, 3% NaCl, 2-3 milliliter mannitol, 0.5 to 1 gram/kg IV. Intubation with target patio 30-35 milligrams. Avoid hypoxia. Urgent neurosurgical consultation. Treat underlying cause, e.g. drain hematoma, antibiotics if abscess, meningitis suspected. Don't wait for CT confirmation if clinical signs are clear and deteriorating. Neurosurgery arrival. Why? Brain herniation causes irreversible brainstem damage within minutes. Early osmotherapy and airway control may reverse impending herniation. Confirmatory tests: non-contrast CTP brain, ICP monitoring, MRI, later if stable. 49. Suspected raised intracranial pressure, ICP. Confirmed signs: declining GCS, pupillary asymmetry or dilation, Cushing's triad, BPHR, irregular breathing, headache, vomiting, altered mental status. Start elevate head of bed to 30 degrees. Mannitol 0.5 to 1 grams/kg IV bolus or hypertonic saline 3% if available. Intubate if GCS 8, maintain oxygenation and avoid hypercapnia. Sedation and paralysis if agitated. Urgent neuroconsult. Don't wait for CT brain or ICP monitor if clinical signs strongly suggest raised ICP. Neurosurgical evaluation to begin stabilizing. Why? Uncontrolled raised ICP can lead to brain herniation and death. Osmotherapy reduces cerebral edema early and buys time. Confirmatory tests, non-contrast CT brain ICP monitoring if available, fundoscopy, papilledema supportive. 50. Snake bite, confirm signs, history of bite, especially in rural sleeping setting, fang marks with local swelling, pain, bleeding from gums, hematuria, viper, ptosis, dysphagia, paralysis, crate cobra, respiratory distress or altered sensorium. Start polyvalent anti-snake venom, ASV as per protocol, usually 8 to 10 vials IV over 1 hour. Support airway, prepare for intubation in neurotoxic bites. Tetanus prophylaxis, analgesics, fluids urine monitoring for AKI signs. Don't wait for coagulation profile, identification of exact species, lab signs of envenomation. Why? Early ASV administration significantly reduces morbidity and mortality. Delay leads to respiratory paralysis, DIC, AKI, or death. Confirmatory tests, whole blood clotting time, WBCT, coagulation profile, renal function tests, CPK, urine for hemoglobin, myoglobin. Identify snake if safely available photo. Final word, from protocols to purpose. This book began with protocols and pathways, but it ends with people. Behind every ventilator, lab report, and monitor lies a human life suspended between fragility and hope. As you've walked through these 50 ICU cases and 50 empiric therapies, you've encountered uncertainty, urgency, and triumph. You've seen how structured thinking can save time and how time can save lives. But beyond clinical reasoning, may you also carry forward something deeper: empathy, calm under pressure, and the humility to keep learning. Critical care is not just about being fast, but it's about being right and being kind. Thank you for walking this journey with me. May this book serve not as a conclusion, but as a foundation for the countless lives you are yet to save. Dr. Kenil Shah, author and forever a student of medicine. Thank you for listening. To everyone who took the time to listen to my audiobook, thank you from the bottom of my heart. I hope it brought clarity, confidence, and practical insights you can apply in your daily practice. If even one lesson helps you make a difference at the bedside, then this journey was worth it. Keep learning, keep growing, and thank you for being part of this mission. Explore the full series. If you found this audiobook valuable, don't miss the other books in the series designed to strengthen your ICU knowledge from every angle. Book 1, ICU for Beginners, a complete textbook-style guide covering everything from trial basics to performing ICU procedures, perfect for building a strong foundation. Book 2, ICU Essentials, features 50 common ICU case presentations with step-by-step empiric therapy strategies to sharpen your clinical reasoning. Book 3, The Ultimate Interpretation Handbook. Learn how to interpret everything from basic blood tests to advanced imaging like coronary angiography, including how different report combinations guide clinical decisions. Book 4, Chronic Code, focuses on the real-world management of chronic conditions with dynamic drug adjustments tailored to patient needs. Book 5, Say It Simple, a practical guide to communicating critical medical information to patients and families in clear, compassionate, jargon-free language. Whether you're a beginner or a working clinician, each book offers something unique to elevate your practice.